in a way that, in my experience, no one else had ever done. And so to many generations of people who got interested in cardiology, he really became a kind of a linchpin to making those kinds of connections about the problems we faced. And I'm sure I speak for many others in saying that we appreciated enormously his contributions to our education, as well as to the way that he's enhanced the cardiology literature with his running of the American Journal. It gives me great pleasure to welcome Dr. William C. Roberts.
Wow, that's quite a nice introduction, Dr. Rychek. I appreciate that, those gracious words very much indeed. Thank you, Dr. Joyner. It's a pleasure being here. Dr. Rychek has been on the editorial board of the American Journal of Cardiology as long as I've been on it, and he reviews, I would say, about 10 manuscripts a year. Gets very little credit for that, but he's one of the people that I can really count on for an opinion, and it's easy to be an editor if one has reviewers such as Dr. Rychek. This is an interesting title that Dr. Rychek chose for me to talk about, cardiac manifestations of systemic diseases, and I must admit that I thought, well, I guess he wants me to talk about what the heart's like in lupus and rheumatoid arthritis and a lot of different things. And I thought, well, the number one is atherosclerosis, so I'm going to limit it to that if I might. That sure made it easier for me. Let me, for years I'd get annoyed at people who would show pictures of their institution, but since I'm in the business, so to speak now, I figure one of my jobs is to inform the cardiovascular community that there are two Baylors, one's in Dallas and one's in Houston, and I'm at the one in Dallas. Now, the Baylor in Houston is called Baylor College of Medicine, and that medical school started here in Dallas, and it was sold to Houston in World War II. We still have a dental school and a very large house staff. The medical school in Houston is one of the few in the country unconnected with a university. The old Hahnemann was another one. And this is the only hospital that I'm aware of that is connected to a university without now a medical school. As everybody knows, cardiovascular disease costs a great deal of money. These were the estimated costs. I think they came out about this way in 1995. As you can see, the biggest cost of hospitalization. So if we can keep people out of the hospital, the cost of cardiovascular care drops enormously. The red here are the cost of drugs, and they make up a relatively small amount. The green represents physician fees, which in the big picture are relatively small. If you just look at that person next to you, one of you are going to die because of arteries such as this. Now, I know it's the other one, not you, but atherosclerosis, or cardiovascular disease, is going to kill about half of us in this room. The sad thing is that it's clearly hereditary in 1 out of 500 people. There are those who argue, well, it's really 1 out of 200, but the point is that most of us get atherosclerosis because of what we do, not by what genetic makeup we inherited. As you know, heart attacks are enormously common. This is a situation, these are people with fatal and non-fatal heart attacks. After 65, nearly as many women as men have heart attacks. Men, look at this, ages 45 to 64, there are just as many heart attacks in men as after 65. The average age of death from coronary disease in men is 6-0. This is not an old person's disease. That means half of men die before reaching age 60. The average age in women is 68. Ladies, you have 1 in 9 chances of getting cancer of the breast. You have 1 in 2 chances of dying from atherosclerotic disease. What I'd like to do is to try to answer these 6 questions. How much atherosclerosis is needed in the coronary arteries to cause myocardial ischemia? Well, of course, the answer to that is dependent on which method of precision one uses to get the answer. You get one answer with angiography, you get another answer at autopsy, you get another answer with intravascular ultrasonic imaging, etc. The answer that I know about comes from the necropsy table. And if you look at these 4 major coronary arteries in patients with fatal coronary disease, now here, this is a group of patients with acute myocardial infarction, and we used to take these arteries, that still do, off the heart intact, fix them, decalcify them, divide them into little bitty 5-millimeter segments, changing blades a lot so we don't make artifacts of cracks and plaques, and then ask how many of these segments are narrowed 76 to 100%, etc. And it turns out that in acute myocardial infarction, and this is the amount of narrowing by plaque alone, does not include thrombus, about 1/3 of the lengths of these arteries, and that's about 9 out of 27 centimeters if you put them together, are narrowed greater than 75% in cross-sectional area. That is, you make a circle divided into 4 quadrants. Over 3 of those quadrants are obliterated by plaque. Another 1/3 approximately are narrowed 51 to 75%, and only about 5 to 8% even approach normal, and none are really normal. Now, this is in patients with fatal acute myocardial infarction. It turns out the same amount of narrowing is present in patients with sudden coronary death, that is, death outside the hospital. The same amount of narrowing is present in patients with healed myocardial infarction and chronic congestive heart failure. Patients with unstable angina have the worst coronary narrowing of all. Best myocardial function, worst coronary narrowing. Rather than being 34% unstable angina, at least in the patients I've been involved in studying, nearly half of the coronary tree is narrowed over 75% in cross-sectional area. Now, this is an example of a patient with unstable angina. Each one of these represents a single 5-millimeter segment. And just go down these 5-millimeter segments. Left main here was terribly narrowed. In my experience, left main severe narrowing is mainly a problem with unstable angina. L8, left anterior descending. Now, if you're going to blow up a balloon here, where would you blow it up? Here, 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 here. This is everywhere. Well, that little fellow right there looks pretty good. The left circumflex, the dominant artery here, look at this, all the way out. Terrible, terrible disease. Now, you might say, well, Roberts, you're looking at patients on the autopsy table. Surely these patients that walk into my office, they don't have this much narrowing. Not so. At the institution where I am now, we have one surgeon who does endarterectomy every time he puts in a conduit in the right coronary artery, at least if he possibly can. And this is one of these specimens. This is where the ostium of the right coronary artery was there. This is the endarterectomy. All that's atherosclerotic plaque. This is the distal portion, and then these are posterior descending. And this cross-section here is through one of these areas. And what we see is terrible degrees of narrowing. And this endarterectomy is a misnomer, really. It's an endarterectomy plus a mediectomy. You get a lot of media in these things also. Now, the point is that when we look at the right coronary artery, the amount of narrowing by these little 5-millimeter segment approaches in patients who are alive but symptomatic myocardial ischemia, we see the same amount of narrowing in them, in groups of people, as in those at autopsy. So I'm convinced that the big change comes not from the a beginning symptomatic myocardial ischemia state to the fatal state, but from the asymptomatic state to the symptomatic state. So by the time that person walks into your office with angina, or you get the call to go to the emergency room because of acute myocardial infarction, or the call that so-and-so has just collapsed at home, that person has severe coronary narrowing. Question 2, what do atherosclerotic plaques consist of? Now, I'm not talking about plaques in a 10-year-old child, 20-year-old young man or woman. I'm talking about these plaques in patients with fatal coronary disease. Or, I think really, it could be symptomatic myocardial ischemia. Well, the answer to the question is shown in this slide. This data was done when I was at NIH, mainly by my colleague at the time, Dr. Amy Kragel. She was very good with computers, and these 5-millimeter segments were put on a computer apparatus, and then with a pen, you could trace out the various components of the plaques. Now, these are little plaques here. These are ones that cause no more than 25% cross-sectional area narrowing. And these over here, plaques were so big that they totally occluded the lumen, or nearly so. Now, these were patients with fatal coronary disease. All of them were over 40 years of age. And what we see is that fibrous tissue is by far the dominant component of coronary plaques, not necessarily in the aorta, but coronary plaques in patients with fatal coronary disease. The yellow represents dense or acellular fibrous tissue. The red represents cellular fibrous tissue. Even in the little plaques, it was nearly entirely fibrous tissue. Calcium is relatively small, and only in plaques narrowing the lumen greater than 50% in cross-sectional area. Pultaceous debris really means extracellular lipid, relatively small, and foam cells are relatively uncommon in patients over 40. They are relatively common under 40. So the answer to the question, what do the atherosclerotic plaques consist of in patients with fatal coronary disease, the answer is fibrous tissue predominantly. Question 3, how many direct atherosclerotic risk factors exist? Now, the key word here, of course, is direct, and what I mean by that is what risk factor or factors do you have to have in order to have atherosclerosis? Do you have to be hypertensive? Anybody? No. So that is not a direct risk factor. Do you have to be a cigarette smoker? No. So that is not a direct atherosclerotic risk factor. Do you have to have diabetes? No. In my view, there's only one direct atherosclerotic risk factor, and that's a total cholesterol level or an LDL cholesterol level greater than a total greater than 150 and an LDL greater than 100. Now, you can argue, well, everybody who walks into my office has a total cholesterol greater than 150, and I would suggest that everybody who walks into your office is a candidate for atherosclerosis. Now, it's my understanding that when we are born, our umbilical blood has a total cholesterol of about 75 milligrams per deciliter. Within 2 weeks of life, it shoots up to about 150, and then it stays about 150 in this country, in the Western world, until we're about 20, and then it gradually starts going up. If we could keep this level what it was when we were graduating from high school, the health of this nation would skyrocket. I can tell you that pure vegetarians have a total cholesterol of about 135, 140. In the 1960s, I had a trip to Central Africa. It really was an eye-opener for me. And I spent a week in Kampala, Uganda, and I examined about 500 hearts. And these hearts were big. Systemic hypertension is really a very major problem in Africa. And so here I was looking at all these big hearts, but saw hardly any atherosclerotic plaques. And I learned that the total cholesterol levels were 135, 120, 110, 100, That 150 is a very important number. Now, that doesn't mean that these are not important. High blood pressure, if you want to prevent stroke, if you want to prevent aortic dissection, you have to keep your blood pressure down. It's as simple as that. You can't be healthy and smoke cigarettes. Diabetes, at least after age 40 or 50, is primarily a problem of obesity, and we can prevent that. Now, this is a slide showing the frequency of very high cholesterol levels. That is greater than 240 milligrams per deciliter. And what we see here is that earlier in life, men, shown here in yellow, there's a higher percent of men than women with these higher levels. Men sort of go to pot between 35 and 44, really shoot up. Now look here, ladies, after menopause, the percent of women with total cholesterol levels greater than 240 is higher than that in men. Now, it may be that the men with the higher levels earlier in life are no longer available to be studied out here. But after age of 55, we're approaching, ladies, about 40% of you have total cholesterol levels greater than 240. A very high number. Now, as you know, total cholesterol is equals the LDL. I think of the L as lousy cholesterol, and the H as the healthy cholesterol, plus the triglyceride level divided by 5 or 6. Now, what this shows is that in most of us, the HDL is about the same most of our life. If we are runners for a period of time or marathoners, it may shoot up for a while. But in general, it's about the same all our life, and women have higher levels than do men. The LDL, men have higher levels earlier in life, and women have higher levels later in life. Question 4, what factors indicate that cholesterol causes atherosclerosis? If you were making a case to the jury that the cause of atherosclerosis is an elevated cholesterol level, what arguments would you use to support that thesis? Well, these are the ones that I would use. The receptor one is not on this slide. This all started, as you know, about 1908 by some Russian physiologists who they first fed raw red meat, and then they fed fat, and then they fed pure egg yolk, essentially cholesterol, to certain animals. Which ones did they choose? They chose rabbits. You can only produce atherosclerosis in an herbivore. You can give your dog or cat all the cholesterol, all the fat you want, and you cannot produce an atherosclerotic plaque. Now, if you take a human being and put them down and just pour fat and pour cholesterol in them over several years, can you produce an atherosclerotic plaque? The answer is of course. And that tells us a lot about what we basically fundamentally are. Now, the second thing that was found was the biochemists came in and they saw these plaques in the arteries and they plucked them off and then they ground them up and they found cholesterol within them. The third thing that happened were the international epidemiologic studies after World War II. Ansel Keys was the instigator there. Ansel Keys, in my view, is a great man. He's 92 years old. He's healthy, still living on the French Riviera, thank you. But at any rate, the studies he did, I conclude from them this statement. Atherosclerotic plaques large enough to produce clinical problems occur only in people having serum total cholesterols greater than 150 or LDLs greater than 100. This item 4, 5, and 6 here will really solidify the last decade. The higher the blood total cholesterol level, the greater the chance of having symptomatic atherosclerotic disease, the greater the chance of dying from atherosclerotic disease, and the greater the extent of the atherosclerotic plaques. Item 5 here, 2 major studies in the 80s and one recently. Lowering the blood total cholesterol level decreases the chances of fatal or non-fatal atherosclerotic disease. A simple statement, cost millions of dollars to get that answer. And in statement 6 here, most of the studies in 6 were published in 1990. Atherosclerotic plaques regress, or at least they have that potential when high blood cholesterol levels are lowered. Also, the frequency of events decrease, progression is less. Now, this is Ansel Keys' famous 7-nation study. He went to these 7 countries, studied approximately 13,000 people, and found that the clinical evidence of myocardial ischemia was quite low in certain populations, quite high in others. Now, in Japan, southern Japan, they studied the average total cholesterol. These studies were done in the 60s primarily. At that time, only 10% of the calories that the adult Japanese were eating were coming from fat. Now they're up to 23%. But the average total cholesterol was about 150, a very narrow bell-shaped curve. East Finland, about 45% of their calories were coming from fat, and their average total cholesterol was averaging about close to 300. I like this study by Stamler and et al. This was published 1986. The reason I like it is look at the enormous number of people studied, over 350,000. They were all men, sorry ladies, aged 35 to 57 when they entered the study. They were all asymptomatic. They were divided into 10 groups according to their serum total cholesterol. And what it shows so nicely is as that level goes up, 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 and up, the coronary artery mortality, and this is only a 6-year mortality, it's higher at 10, it's higher at 12, it's higher at 15, goes up, 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 and up. No study shows it better that number is very important, and the higher that number, the greater the risk. Now, it's not only what that number is, but it's how long, the duration that you have that number. Now, this slide was prepared from study of the 2 primary prevention trials that were published in the 1980s, the Lipid Research Clinic and the Helsinki Heart Study. Now, those studies were analyzed by intention to treat method. So if you were put in the treatment group, you stayed in that group, irrespective of whether you took the drug or not. Now, if you analyze those studies by those who took the drug versus those who didn't, you get a 3-for-1. And that is, if you look at total cholesterol, and if that is dropped by 10%, and let's say from 200 to 180, you decrease your chance of a heart attack by 30%. Now, that's the kind of company I want to invest in. Unfortunately, the opposite is true. If you raise your total cholesterol 10%, the chance of a heart attack increases 30%. This is the recently studied November, I believe, 1995, West of Scotland study. And this, too, is a primary prevention trial. At least it's a 95% primary prevention trial. And the beauty of this study is that a statin drug was used. In the studies in the 1960s, the statin drug was not used, and the statin drug is the real world, and I'll come back to that later. But look what happened to these people. Now, the dropout rate in this study was 30%. So, and this was an intention to treat analysis. If the dropout rate hadn't been so high, I think these risk reductions would have even been higher than this. But 31% decrease in non-fatal myocardial infarction or coronary artery death, 31% non-fatal myocardial infarction, all cardiovascular deaths decrease, shows big dividends of getting these levels down. Now, the 4S study is the best so far of the secondary prevention trials. Now, this means that these people already had an atherosclerotic event. And in this study, published in 1994, 4,000, the 4 means 4,444 patients. The S can mean either Scandinavian countries, the 5 of them, or simvastatin, whichever one you choose. But at any rate, this study went on for 5.2 years. 80% of these patients had had a myocardial infarction. 20% had had angina. And the doses of simvastatin used here were 20 or 40 milligrams. The goal was to get everybody's total cholesterol less than 200. But look at these enormous reductions. Overall risk of death decreased 30%, risk of coronary death 42%. Is that focused or is it me? It doesn't, well, maybe I can do that. Not doing any good. Yeah, that's better. Look at this one. Risk of revascularization decreased 37%. That is bypass or angioplasty. In Scandinavia, those operations, those procedures are not done very often. I'll tell you, if this were transferred to my hospital, it would probably be a 75% reduction. Very, very important. Now, there are at least 17 trials now, which are angiographic trials. That is a baseline angiogram after an event. And then 1 year, 2 years, 2.5 or 4 years later, a repeat angiogram. And all of these studies, except the first one, and that was a problem of analysis, showed that there is evidence of plaque shrinkage in the treatment group compared to the non-treatment group. That's pretty good information. Now, how does plaque regression occur? Nobody knows for certain, because you can only do an autopsy once, really. But the idea is that if you have some lipid here and you shrink that if you have an event, you have at least one artery narrowed greater than 75% in cross-sectional area. And it may be, if you can get some of this fat out of there, it can open that lumen so that it is now less than 75% narrowed. And that, amazingly, is as if there is no narrowing at all. You have to narrow a lumen greater than 75% before there's flow diminution, as I understand it. Now, progression or plaque getting bigger with time is probably even more important than regression. And in the treatment group, in all of these studies, the treatment group had less evidence of plaque progression than in the non-treatment group. Now, none of these studies took patients down to a total cholesterol of 150. None of them took an LDL less than 100 as a goal. If that had been done, I think this would have been even more dramatic. Even more important, certainly to the patient, rather than plaque progression or regression, is what about, doctor, don't let me have another heart attack. And all of these studies have shown that these lipid-lowering drugs or pure vegetarian diet or whatever are very useful in decreasing subsequent heart attacks. Look at this. In the STARS study, up to a 90% reduction in subsequent heart attacks in the treatment group compared to the non-treatment group. In the FAT study, one of the very best ones, nearly 80%, the POSH was partial ileal bypass, 60% reduction. That lowers total cholesterol and LDL compared to the non-treatment group. Now, everybody knows if you have a heart attack, you ought to be on an aspirin tablet, and that gives you about a 25% reduction in subsequent events. Beta blocker may give you about a 25% reduction. Maybe an ACE inhibitor give you maybe 15%. Look what a lipid lowering has the capacity of doing. And yet, the lipid lowering is the last medicine thought about, and yet may be the best one of them all. Question 5, how can symptomatic atherosclerosis be prevented, and if present, how can it be arrested? The answer to that is easy. If your total cholesterol is 150 or less, the challenge in life is to keep it there. And if it's 150 or less, the evidence is, in my view, that you don't form a plaque. Now, if it's greater than that, the challenge in life, in a way, is to get it to 150 area or below. Question 6, how can we do that? How can normal cholesterol levels be prevented from rising, and how can elevated levels be lowered to normal? Well, we all know the answer. We got to do 3 things. We've got to decrease the quantity of cholesterol we take in, we've got to decrease the quantity of saturated fat we take in, and we probably have to decrease the quantity of total calories we take in. This has to do with cholesterol. As we increase our cholesterol intake, cholesterol in the blood goes up. 3 different studies showing the same thing. Now, it doesn't work perfect. That's the way it is in groups of people. When you're looking at that one person across from your desk, you don't know whether that person is going to be a good dietary responder or not. Some people can eat 3 eggs and the cholesterol will shoot up. Others can eat 3 eggs and it won't change. So there's considerable individual variability. Now, actually, I don't worry too much about cholesterol. As you know, cholesterol comes from animals and their products, and that's it. We only take in 400 to 500 milligrams of it every day. It's hardly enough to get a calorie out of that. How can you picture 400 to 500 milligrams? I can tell you that a toothpick weighs 100 milligrams. So we take in the equivalent of about 5 toothpicks of cholesterol every day. Now, half of it is from the visible and non-visible eggs we eat. So if we give up the eggs, we're doing pretty well. The rest, most of the rest of it comes from cows. We call it beef, but it's really bovine muscle. That's about 28%. Milk's about 9%, cheese 5%, butter's 4%. So if we give up eggs, if we give up cows, we've really put a big hole in the cholesterol picture. Now, fat is the real villain. The problem with fat is that about 1/3 of it is saturated. And when that saturated fat, it's hard to get the answer to the question, how does saturated fat increase cholesterol levels? I've asked 100 people that question. And the best I can figure is when saturated fat enters our bodies, it goes through the cycle and it's essentially converted into cholesterol. Many sources of fat, we're talking here about 120,000 milligrams maybe in most of us. I tell you, in Texas, the average in males in Texas, adults, is about 160 grams a day. I saw a study recently, the average American is eating about 140 grams of fat every day. In Amarillo, Texas, they're up to about 180 grams of fat every day. They've got a place up there that sells 50-ounce steaks. And if you eat that sucker in 1 hour, they'll give it to you free. 50 ounces of bovine muscle. Isn't that unbelievable? Now, none of us should eat more than 75 grams of fat every day. Now, a deck of cards weighs 75 grams. We would all be better off if none of us ate over 50 grams of fat every day. Now, every one of these fats have the saturated component and the mono and the poly. The poly unsaturated and the mono unsaturated either have a neutral effect on our cholesterol levels or they lower them. The saturated clearly raise them. And look at some of these on the right. These are what we need to avoid. Coconut oil, 92% saturated fat. Palm kernel, 86%. Butterfat, 66%. Now, there's some evidence that from Grundy's group that monounsaturated is better for us than polyunsaturated. Olive oil, for example, is 77% monounsaturated. I was in Italy in December. I stayed at someone's house over there, and they don't even buy butter, margarine. They only buy olive oil, and they put cooking olive oil, and they put olive oil on the bread. And if you want to get a good grease job, there's no better place than the fast food chain. As you know, 1 out of every $2 spent for food eaten outside the home in the USA is spent in a fast food chain. 20% of Americans eat their lunch every day at a fast food chain. 5% their breakfast, 13% their supper. These authors went around to try to determine the ingredients of the hamburgers and so on in these fast food chains. At the moment, Carl's Jr. Double Western Bacon Cheeseburger is the coronary artery bypass special. And it's closely followed by the Jack in the Box Ultimate Cheeseburger and the Burger King Double Whopper with cheese. Now, we're talking about 1,000 calories in that hamburger. And if you take that sucker and squeeze it real hard, you can come up with about 15 teaspoons, not grams, but teaspoons of fat in that single hamburger. Much of that is saturated. Now, none of us should eat more than 1,800 milligrams of sodium. That's not salt, that's sodium alone every day. We'd be better off if we ate less than that. But you can get that right there in this single hamburger. I'll have the half-pound double deluxe bacon steer burger, please. You want chemotherapy with that? That's the truth. There was a book, some of you probably heard Bill Castelli talk on this subject, but Castelli calls the arches of McDonald's the entrances into the pearly gates, and I think he's right. There's a McDonald's within 3 minutes of 50% of places where people live in the USA. 50% of us have a McDonald's within 3 minutes. There was a book that appeared a few years ago entitled In One Day, and the author asked the question, what do we consume in the USA every 24 hours? Well, about 815 billion calories of food are consumed every day, roughly 200 billion more than we need. Now, those 200 billion every day excess would feed the whole country of Mexico, no problem. In 1990, folks, we reached 60%. 3 out of every 5 adults age 18 and over in the USA are overweight. When I was at NIH, we had a lot of foreign visitors. Whenever they walked into my office, I'd always ask them, what strikes you most about Americans? Of course, that produced a lot of different answers. Answer number 1 was how many fat people we have in this country, and no nation in the history of the planet has seen the problem of overweightness and obesity as we have in this country. Nearly 100,000 cattle are slaughtered every day, yielding 60 million pounds of red meat. Now, as you know, we have about 260 million people in this country and about 100 million cows. And every day we kill about 100,000 of them. And we do it differently in the USA and Canada than in the rest of the world. As you know, we bring them into these feedlots. They'll last 5 or 6 months of life, and there we feed them 20, 25 pounds of grain and soybean every day. And why do we do that? We do that, of course, to make them fat, because when they're fat, they taste better. And then we kill them, and then they kill us. And that's the way the cycle works. Now, we also kill about 250,000 hogs every day and eat 4 million pounds of bacon. Bacon is really the pits. It's about 80-85% pure fat. Now, if you don't know what it is, make a hot dog out of it, and we eat about 47 million of them every day. McDonald's puts 2,500 cows on their tables every day. Dairy cows yield 47 million gallons of milk every day. We eat about 170 million eggs every day. This is an old slide. This is now... Folks, if you're a chicken, don't wander into the USA. We kill now about 19 million chickens every day in the USA. We eat about 50 million pounds of sugar every day, an average of 21 teaspoons apiece. Can you imagine waking up in the morning, looking at your bedside table, and seeing 21 teaspoons of sugar out there? These processed foods we all eat are loaded with sugar, and they're loaded with salt. We also drink about 16 million gallons of beer and ale and 1.5 million gallons of hard liquor, enough to make 26 million Americans thoroughly drunk every day. 3,000 to 4,000 teenagers take up smoking every day in the USA. I like this statement by William Collins from Philadelphia. He says, the carnivore animal has almost an unlimited capacity to handle saturated fats and cholesterol, whereas the vegetarian and herbivorous animals have a very restricted capacity to handle these food components. It is virtually impossible to produce atherosclerosis in the dog, even when 100 grams of cholesterol, now that's 200 times the average daily intake for humans in the USA, plus a quarter pound of butterfat are added to its meat ration. In contrast, adding only 2 grams of cholesterol daily to a rabbit's chow for 2 months produces striking fatty changes in its arterial wall. Now, are we more like the rabbit or more like the dog? Let's examine that a little closer. Now, when you look down at your appendages, do you see claws or do you see hands we're supposed to be using for gathering these fruits and vegetables we're supposed to be eating? Now, there are those who argue, well, these teeth in the front of our mouth are sharp, so that makes us omnivores, but most of them are flat for grinding. Now, the intestinal tract of a human being could easily, the small intestine, it's about 26 feet long, could stretch across this stage with no problem. The intestinal tract, on the other hand, of a dog or cat, is short. You give them something to eat, they got to go outside in a few minutes. Now, when you cool your body, do you pant like a dog or do you sweat? When you drink water, you lap it like your cat or do you sip it? I don't know any human beings that make their own vitamin C. Of course, we're over here. Folks, I think we're one of these carnivores, and we certainly conduct our lives as if we were, but I would suggest, as have many others, that basically, fundamentally, this is where we are, right there. Now, there are those who've studied populations where meat, flesh, is not consumed or rarely consumed. And these are diseases that are fairly infrequent in pure vegetarian societies. Atherosclerosis is going to kill half of us in this room. High blood pressure, we have 160 million Americans over age 20, and 60 million have blood pressures greater than 140 over 90. Ed Fries from Washington has studied people who eat no salt, few islands in the world, and their blood pressure at birth, our blood pressure at birth, is 90 over 60. But if individuals do eat no salt, zero, blood pressure is 90 over 60 at 20, 90 over 60 at 40, 90 over 60 at 80, etc. It does not go up with age. It's abnormal to go up with age. Two of the three most common cancers, cancer of the colon, breast about 5% apparently is hereditary, but 95% is not. Prostate gland, I saw a paper a while back, heavy meat eaters have a lot more cancer of the prostate than light meat eaters. Diabetes after age 50 is really unheard of almost in pure vegetarian societies. They're not obese, they're not bothered by peptic ulcer, constipation, hemorrhoids, diverticulosis, appendicitis, irritable bowel. No stones in the kidney, gallbladder. Look at this, ladies, osteoporosis. For some reason, osteoporosis is more common in women than in men. It's estimated in this country that by age 65, the average woman has lost 35% of her skeleton. Why? Because you're not taking in, or we're not taking in enough calcium. The answer, according to a lot of people, is we all take in too much protein, too much flesh. And the more protein we take in, the more calcium we lose in the urine. Can we change our health? Of course we can. This slide comes from the Harvard School of Public Health. It has to do with body weight, shown in the horizontal axis here, and what they call mortality ratio, which simply means when we die. And what it shows, whether you're a man or whether you're a woman, the more we weigh, the sooner we die. Now, we can all point to the Winston Churchills, but they're the exception. In groups of people, the more we weigh, the sooner we die. Overweightness in this nation is a national disgrace. This slide has to do not with overweightness, but with obesity. Obesity being defined as greater than 20% over ideal body weight, which means if you should weigh 160, you weigh 200. Now that's obese. And look at this. Black women in this nation, nearly 45% are frankly obese. White people in this nation, about 25%, are obese. The percent overweight is at least 60%. This slide, it took World War II to produce. As you know, 1939 and 1945, there were some countries that did not have much red meat available, and not much butter, and not much cheese, and not much milk. And what happened to the cardiovascular death rate? Well, in Sweden, boom, it fell. In Finland, boom, it fell. In Norway, boom, it fell. In the USA, it just kept on going up. Can we change our health? Of course we can. This slide has to do with cancer of the breast. Well, how's he talking about cancer of the breast? On the horizontal axis here is the fat consumed grams per day by adults in these various countries around the world. And here we are, a little over 140 grams of fat a day, USA, and we have one of the highest frequencies of cancer of the breast in the world. Now, this slide could just as easily be cancer of the colon. It could just as easily be systemic hypertension, and it could just as easily be atherosclerosis. The quantity of fat consumed by any society, the lower the frequency of our two most common cardiovascular conditions and two of the three most common cancers. Can we change that? Of course we can. Now, this is the most frequently prescribed diet by physicians in the USA. 30% of calories from fat. And most of us are eating 37, 38, 39, 40% of our calories from fat. Now, what does it do to the total and LDL cholesterol level if you decrease the percent of calories from fat by 25%? If we go from 40% of calories down to 30% of calories from fat. What does it do to these levels? Anybody? What? How much does it lower total cholesterol? The average, this was a beautiful study by Huntinghack, April 29, 1994, New England Journal of Medicine, 5% reduction. LDL, average, 5% reduction. So don't send that patient home after a heart attack and expect miracles by lowering the total cholesterol by 5% or LDL by 5%. Give them a drug, get it down. Now, if you're looking at a single patient, the variability here was enormous. Some people with just a 25% drop in percent of calories got a 20% drop in total and LDL, and actually some of them went up 20%. But on the average, only a 5% reduction. If you're going to use diet to get a lowering of cholesterol of significance, you've got to go down here to 20% of calories from fat. Vegetarians are down here at 10%. I love these lipid-lowering drugs, particularly the statin drugs. I think the rest of them are nearly a waste of time. Most people started on these other drugs end up on a statin drug. I think the statin drugs are to atherosclerosis what penicillin is and was to infectious disease. These truly are miracle drugs in my view. Their toxicity is virtually nil. There was one person out in the simvastatin study of 2,220 people for 5.2 years that developed myopathy, that is weakness and legs and so on. That patient was taken off the drug and it went away immediately. Now, a year ago, I was advocating low doses of these drugs. Today, if anybody comes to see me, I start them on maximal doses right away, particularly if they've had any atherosclerotic events. I realize that's a bit radical, but I don't think it's radical. Now, these are the indications for drug therapy by our adult treatment panel 2. And the idea is that if you have no other risk factors like being a man or elevated blood pressure and no atherosclerotic events, 190 LDL is the magical number. And if the LDL is greater than 190, put them on a drug and with the goal of getting that LDL to less than 160. Now, if they have 2 other risk factors, man, high blood pressure, smoke cigarettes, the magical number is 160, and the goal is to get it less than 130. But if you've had an atherosclerotic event, the magical number becomes 130 with the idea of getting it to less than 100. Now, I say to you that if it is useful to get the LDL to less than 100 after an event, surely it's useful to get it there before the event. Today, in my view, the greatest challenge in this therapy is treating before an event. And nobody knows how to do that perfectly. But that's where we've got to go in order to change the frequency and the devastation that atherosclerosis is doing to this nation and the Western world. Now, in my view, it's very important to know the varying powers of these drugs. All of them, this one is an artificial one. These are from fungus. But they all work the same way, and as far as I'm concerned, they're all good drugs. The side effects of all of them are minimal, and they're the same. Now, simvastatin at 10 milligrams is equivalent to lovastatin at 20, pravastatin at 20, and fluvastatin. There's going to be a paper coming out soon that's going to show that it's not a 4-to-1, but this may be 60 milligrams. It may be as high as 6-to-1 in power. 20 milligrams of simvastatin is obvious. Now, 80 milligrams of fluvastatin is not approved. So you can't get the medium dose of fluvastatin at the moment. You can give it, but it's not approved at that dose. 40 milligrams of simvastatin, 80 milligrams of pravastatin is not approved yet. And to my knowledge, they've told me that they're not applying for that. Fluvastatin has applied for 80 milligrams, and I think that's soon going to be approved, but it's not approved yet for 160. Now, Merck has done something very interesting, and that is they're charging the same thing per month for 20 milligrams of simvastatin and 40 milligrams of simvastatin. You can get 20 milligrams for $93 a month, and you can get 40 for $94 a month. Now, this drug at 80 milligrams is quite expensive, and these are not approved. Atorvastatin, which is the Park Davis Warner Lambert drug, is probably going to come out next year. And I'm not entirely sure what the equivalent doses are, but there's no question atorvastatin is going to be the most powerful of them all. Whether it's going to have more side effects, I don't know. But it's my understanding that Merck now has studies going on studying simvastatin at 80 milligrams and at 160 milligrams. These drugs are so safe that higher doses are not bad. At minimal doses, at these, side effects are no more than placebo. At the higher doses, they're not. The beauty of the 4S study is 37% of the people, that is about 900 people, were treated for over 5 years with 40 milligrams of simvastatin. I have no stocks in any pharmaceutical company, folks. So I'm not pushing a drug because of personal interest. I think these are wonderful drugs. Now, in the average person with a heart attack, the LDL is about 148. You're not going to get it to less than 100 on minimal doses. If I had a heart attack, I'd be on 40 milligrams of simvastatin tomorrow. If I had angioplasty, I'd be on the same. If I had bypass, I'd be the same. Now, if you start out with an LDL of 165, it's a dream to think you're going to get there at low doses. My view is start at high doses. If you knock the dickens out of the cholesterol, then you can drop it back. This is the problem, and this is one of the reasons I recommend the higher doses, is that 50% of the people quit taking these lipid-lowering drugs within 1 year. 50%. Only about a quarter are still on it after 2 years. So it's not enough to start somebody on the drug. You've got to kick them and keep harping to keep them to take that drug. And very few people who have started on these drugs reach goal. Very, very few. Let me show you this about the 4S study. This is a wonderful study, and it clearly shows the great benefit of cholesterol-lowering drugs after heart attacks. If you're not putting your patients who've had heart attacks on cholesterol-lowering drugs, you are not practicing modern-day medicine. And folks, this is in the courts right now, so you better listen. Look at this. Total events, even in the simvastatin group, despite this good reduction in cholesterol levels, not down to the 150, but under 200, they still had a lot of events in this 5-point-year period. Now, in placebo, it was much less in placebo. But this, to me, shows that we got to start treating these patients before an event. Because even if you get their cholesterol levels under 200, that's not enough. To prevent an event, you got to get it down to the 150 range. Now, this is my view in a nutshell. If you've got familial hypercholesterolemia, whether you have any events or not, you've got to put these patients on a drug. Diet alone will not do it, and this is the importance of identifying familial hypercholesterolemia early, is that these people need to go on a drug. Anybody with symptomatic atherosclerosis, in my view, should be on the drug. It's the most important of all drugs. It's better than aspirin, it's better than beta blockers, it's better than calcium antagonists, it's better than ACE inhibitors, and it's the least thought of one. But angina, acute myocardial infarction, TIAs, intestinal angina, claudication. Now, what about all these people in between? I'll tell you, if I had an abdominal aortic aneurysm, I'd be on this cholesterol-lowering drug. I think that's a combination of atherosclerosis plus hypertension. If I had asymptomatic carotid disease, I'd be on the drug. What if you do a chest x-ray and you see calcium up there in the aortic knob? That represents atherosclerosis. What about the person at very high risk, the 50-year-old man who comes in, he's obese, got high blood pressure, heavy cigarette smoker, cholesterol levels 230, 240. That person is sitting on a dynamite keg. What if you do an echocardiogram and you see that atherosclerotic plaque up there in the aorta like this? Should that person be on the drug? What about an abdominal aortic aneurysm? I say yes. What about aortic stenosis in the person over 65 years of age? The evidence, in my view, is that this is atherosclerotic in origin. Aortic stenosis in older people do not occur in pure vegetarian societies, as I understand it. What about calcium in the mitral annulus? As far as I'm concerned, this is an atherosclerotic lesion. If you look at people over age 65 and have calcium in the mitral annulus, 100% of them also have calcium in the coronary arteries, which means they have atherosclerosis. If they have aortic stenosis with a three-cuspid valve and over 65, they got atherosclerosis in the coronary arteries. If you have aortic stenosis and you're 75 and you have clean coronary arteries, you have a congenitally bicuspid aortic valve. I'll bet you on that. If we were to look underneath our posterior mitral leaflets or down on our aortic valve cusp, nearly everybody in this room would have some yellow deposits there of foam cells. And it's those foam cells that can break down later in life to calcify. This is next to last. What I show here are two curves. This would be primary prevention. People have not had an atherosclerotic event. This line here would be those who've had an atherosclerotic event. These are the cholesterol levels here at the total, and these are the relative risk of an atherosclerotic event. And what this slide shows is no matter where you start on either of these lines, for every 40 milligrams you lower that total cholesterol, you decrease the chance of an atherosclerotic event in half. An event shifts the line to the left. So here, if you start at 270 to 230, you decrease it in half. 230 to 190, decrease it in half. 190 to 160 or so, now this is just average, but that's too high. But the point is, wherever you're getting it down, pays big dividends. This slide has to do with high blood pressure. It comes from studies done by Ed Froelich in 1972. He asked the question, how many people in 1972 in the USA have high blood pressure? And how many of those were being treated? What he found is that of every 100 people in the USA in 1972 with high blood pressure, 40 did not know they had a high blood pressure. Of the 60 who knew they had it, only 30 were seeing a physician and 30 were not. And of those 30 seeing a physician, only 15 were being adequately treated. Now, if we could trade hypertension here for hypercholesterolemia, rather than being 15% down here, folks, it would be about 2%. 2%. It's a national disgrace. This slide comes from a woman who is 103 years of age. This lady, these are her major coronary arteries at sites of maximal narrowing. This is a left main, a right here. That was the biggest plaque in her body. And this is left anterior descending, just beautiful artery, 103 years of age. The reason I show it is to point out that we don't have to get atherosclerosis just because we get older. Atherosclerosis is not a degenerative disease. We are the degenerates, I'm afraid. This poor lady was run over by an automobile. Remember, folks, 150, that's the key. If you don't want to form a plaque, get your total cholesterol to 150. And if you don't want any more plaques to form, get it down to that number. Thank you very much. Yeah.
Do you start on the lipid lowering agent for every patient who had MI, even though the cholesterol level is within the normal?
What do you call normal?
Like below 130?
I mean LDL below 130?
Right.
Yeah. As far as I'm concerned, if somebody has a heart attack or unstable angina, it's confirmed that they have terribly narrowed coronary arteries, I don't really care too much what their numbers are. Whatever their numbers are, it's too high for that particular patient. Now, if I had a heart attack, I would try to get my LDL to less than 80. Not less than 100, but less than 80. And that's the best thing you can do for somebody who's had a heart attack. Well, I only know of one paper on chelation therapy. It was published in Circulation, and it said it was no good. Yes, ma'am.
I'm just curious about what we could do to get people interested in this enough so that they would follow through with what we're learning. For example, what we had for lunch today. It's always interesting to me when I go to these lectures about atherosclerosis and heart disease that the lectures are always cheap and
Well, I'll tell you my view, is that I think when doctors quit smoking, it had a major impact on non-physicians. Or not just doctors, but when healthcare people quit smoking, it had a major impact. Now, when physicians invite others and healthcare people invite others over to their house, and they cook out in the backyard and cook bovine muscle, or put a pig on the skillet, we are not producing a meaningful message. It's an absolute joke. Now, when a doctor is 30% over ideal body weight and is trying to convince a patient to lose weight, come on. It's fraudulent. We must set the example, and the problem is most of us are not willing to do so. But the health of this nation will not change until doctors lead the way and healthcare people lead the way. What's happening in California is leading the nation, and healthcare people out there are taking it away from physicians. Best books I've read in recent years were not by physicians. Yes, ma'am.